My name is Carlos Becerra. I'm a medical oncologist, practices at Baylor University Medical Center in Dallas, Texas. I do mostly GI oncology, and I also have a phase 1 clinic. Can you describe the total neoadjuvant chemotherapy, TNT approach to rectal cancer? In what situations do you prefer this approach? Total neoadjuvant therapy, or TNT, involves the administration of systemic chemotherapy with FOLFOX or FOLFIRINOX, followed by chemotherapy and radiation therapy, or vice versa, followed by surgery for patients with non-metastatic adenocarcinoma of the rectum. The concept of neoadjuvant chemotherapy for rectal cancer builds on the standard of care for rectal cancer, which involves neoadjuvant chemotherapy and radiation therapy, followed by surgical resection of the primary lesion. For the past 25 years, we have gradually improved local control for patients with rectal cancer, with the incorporation of chemotherapy and radiation therapy prior to surgical intervention, and standardize the use of total mesorectal excision by the surgeon. This has led to a very high local control rate with local recurrences of only 4 to 6%. However, distant recurrence rates remain at 20 to 25%. An additional observation from clinicians and investigators is that systemic chemotherapy for patients with metastatic rectal cancer resulted in a very good local control rate of the primary lesion. Therefore, the research question came up on incorporating chemotherapy early prior to surgical resection in order to control micrometastatic disease for two main reasons. The first reason is that systemic recurrence exceeds local recurrences, and the second is that a large proportion of patients do not receive adjuvant chemotherapy after surgery. There are several research groups investigating this approach, and the preliminary results presented at virtual ASCO 2020 with peer-reviewed publications for two of the studies are encouraging, reporting that the approach is feasible with a near doubling of the pathologic complete response rate in the primary tumor, decrease in distant metastasis rate, and improved disease-free survival. For further reading, please refer to abstracts 4008 from virtual ASCO 2020 by Garcia et al. For the OPRA study. The Lancet Oncology Volume 22, Issue 1 from January 1st, 2021 by Becerra for the Rapido study, which was short course radiation followed by either CAPOX or FOLFOX, followed by surgery. And the Lancet Oncology Volume 22, Issue 5 from May 1st of 2021 by Conroy et al. For the Prodigy 23 study, that is neoadjuvant FOLFIRINOX for 6 cycles, followed by standard dose radiation therapy, followed by TME, and then followed by FOLFOX or CAPOX for an additional 6 cycles. I would reserve TNT for patients with node-positive disease by imaging or with bulky primary lesions. For earlier stage disease, I would probably treat patients with a more standard approach of chemotherapy and radiation therapy followed by surgery.
Thank you for watching. Since this interview, new information has been released. And now we go to the update.
There were significant updates in neoadjuvant therapy for rectal cancer at ASCO 2022. Most notable was the late-breaking report by Dr. Cirsik from Memorial Sloan Kettering on 18 patients with MMR-deficient rectal cancer. The trial was a single-arm study in which patients with stage 2 or stage 3 MMR-deficient rectal cancer were treated with the PD-1 inhibitor dostarlimab as a single agent every 3 weeks for 6 months. The trial was designed to enroll 30 patients but a report of the first 18 patients who were enrolled, 17 of whom presented with node-positive disease, showed a 100% response rate, with 14 out of 14 of the patients who had reached 6 months of treatment achieving a complete clinical response. Notably, thus far, none of the patients have required chemotherapy, radiation, or surgery. All of them will be followed very closely for local recurrence and distant recurrence, but thus far no recurrences have occurred, with the longest patient being followed up to 24 months. While there is no doubt that more patients are needed to be enrolled and longer follow-up is required, this study could potentially be immediately practice-changing, particularly because it's going to be very highly unlikely that any randomized trial for this patient population will ever be done for ethical reasons. As an update for the treatment of MMR proficient rectal cancer, Tamberi et al. Presented their phase 2 trial of capecitabine and radiation, followed by the PD-L1 inhibitor durvalumab as perioperative therapy for rectal cancer. This was called the Pandora trial. In this study, patients with stage 2 or stage 3 rectal cancer were treated with standard chemoradiation, which is standard capecitabine 825 milligrams per meter squared twice a day, and in this case, 50.4 gray of radiation over 5 weeks, then followed by durvalumab every 3 weeks for 3 total doses. All patients then went on to have surgery. Out of 55 evaluable patients, 78% of whom had node-positive disease, the complete clinical response rate was 11%, and the complete pathological response as determined after surgery was 35%. Importantly, MMR status was not yet reported as part of this study and actually could have a major impact on the analysis because if a percentage of these patients were MMR deficient, that could really color the overall complete clinical and pathological responses. Additionally, one has to consider that in the NRG GI-002 trial reported by Rama et al. Of FOLFOX followed by chemoradiation with or without pembrolizumab, the path CR rate in the non-pembro arm was still 29%. So it's really unclear if the immunotherapeutic agent is actually adding anything to the path CR rate in this patient population. Finally, Jensen et al. Presented their late-breaking abstract of chemoradiation for patients with low rectal cancers within 6 centimeters of the anal verge. Patients also received capecitabine 825 milligrams per meter squared twice a day, plus 62 grays, so a higher radiation dose over 5 weeks. 107 patients were enrolled, and while this was specifically a low rectal cancer population, the rate of node-positive disease was only 29%. 86% of patients achieved a complete clinical response and were managed with close observation. For the 103 patients followed closely for 2 years, 59% had ongoing no evidence of local or distant recurrent disease, and the 30-month overall survival rate was 95%. These are all very positive results. However, 23 patients did have local recurrence requiring some form of surgery, and the 30-month metastasis-free survival rate was only 85%. Overall, of these 3 trial updates, only the dostarlimab trial was potentially practice-changing. The durvalumab trial was intriguing, but the actual benefit of the addition of immunotherapy remains to be proven in an MMR proficient patient group. And while the Danish 2 trial, the Jensen trial, added to the notion that non-operative management of rectal cancer is a legitimate consideration, questions still remain on which patients and which specific regimens are the best to follow for this treatment paradigm.